Good morning, Dr. Hakim.
Good morning.
Yes, unfortunately, the rest have not been able to join us. They're still struggling with communications, especially those in Juba. So we'll go ahead as promised. People have been waiting for too long. I'm speaking to Dr. Hakim Abe. He's a retired consultant physician living in the base on the Isle of Wight at the moment in the UK. And he's the associate editor of the South Sudan Medical Journal. Dr. Aluzai is a very well-known doctor and has a wide career dating back to South Sudan many, many years ago. Coming to our subject today, which is the subject of the new rise, the spike in COVID-19 in South Sudan currently. This is something that we wanted to discuss with a number of people, including Dr. Aluzai. As they have not arrived now, we will proceed as planned. So welcome, Dr. Aluzai, and thank you very much for giving us this time.
Thank you very much, Mawan. How long have I got to begin with? Because some of the most interesting points in the discussion tend to emerge from the question-answer sessions. For the time being, are we sticking to the 7-minute sort of introductory remarks, and then we can follow that up with any questions later on? Or how do you want us to play?
I think let's make it longer. I think what we'll do now, we'll do ourselves more of a questions and answers session until people join us. Because of the delay, the hosts like Facebook, they cannot wait for 10 minutes, so they did cancel our original broadcast. We had to issue a new one, and I think people are going to delay in joining us. So let's proceed. I'll let you do your presentation as planned, 7 minutes or a bit more. Please talk about how you've prepared it exactly. And then from there, we'll take it from there.
Okay. Good morning, everyone, or afternoon, depending on where you are at this time of the day. The South Sudan Medical Journal, which I founded 13 years ago and continue to be the associate editor, published a special edition dedicated to COVID-19 and directed at healthcare professionals and other people who might read the journal in May 2020. So if you go into www.southsudanmedicaljournal, all as one word.com, you will not only access that issue of the journal, which is dedicated to COVID-19 in South Sudan, but you will also be able to read a report, which we issued only 10 days ago, carried out in the community. There was a research carried out by the Rift Valley Institute, Juba office, involving representative areas in Yei, Awil West, Wau, Rubkona, Juba, and Malakal. We investigated people's attitude towards COVID-19, and of course, some major myths emerged, which we will dispel during the course of the discussion. But for the time being, let's just talk about COVID-19. Now, COVID-19 is a disease caused by a coronavirus. The coronavirus looks like a crown because of the shape of the receptors. And the receptors are the points within the virus which latch onto different parts of the body, enabling the virus to gain entry into the body and causing this disease. Now, the coronavirus, which we talk about, belongs to the same family of viruses, just like the virus that causes the common flu, the common organism. And it's also the same class of organism that caused two other big epidemics, but not pandemics, the so-called SARS, or the Severe Acute Respiratory Syndrome 1, and then the MERS, which was the Middle East Respiratory Syndrome. This occurred in the last 10 years. And now the coronavirus, the coronavirus as we know it today, which has caused the pandemic, is caused by the SARS-CoV-2 virus. And the disease that results from this is known as the COVID-19. They just call it COVID-19 because the WHO agreed this designation so that people know what they're talking about, to distinguish it from all the other diseases. Now, it is probably the biggest pandemic, which is an epidemic that affects the whole world. The biggest pandemic for many, many years. The last one was in 1918, the so-called encephalitis lethargica, which made people feel extremely tired, and it kills millions of people all over the world. Now, the reason why we are discussing COVID-19 with regard to South Sudan is because attitudes vary a lot in South Sudan, and many people are not taking it seriously. If you look in the current issue of Tamajus, Radio Tamajus, you'll find that there are some two graphs there, and one of them showed a spike in the cases of COVID-19 in South Sudan. And that also coincided with Christmas time. It coincided with Christmas time. Even if it is coming down, it's not coming down quickly enough. So it means that interaction between people is quite important. It's so important that unless we can do something about preventing it, we're going to be in a lot of problems. Many people in that Rift Valley Institute report, which is a very, very good report to read. If you go into the South Sudan Medical Journal, it's on the front page, top right-hand corner in the bottom. You can access that report easily online. And a lot of people feel that it's a disease of rich people. It's a disease of people from the West. It's a disease that affects those who live in Juba and have high posts. That's not true. It is simply because sometimes some of the very rich, so-called rich, or people who are influential, tend to ignore the rules of social distancing and so on. And a lot of these people spend their time indoors, whereas in the communities, people spend their time outside. But one important fact that we must note is that 5% of people who are affected by COVID-19 actually die. And something like 15% of the people will get very seriously ill and could die unless they are, in fact, treated appropriately. And 80% of the people will have the disease. It appears mild, but they transmit it to other people. And this is probably why many people feel, well, we live in the community, we live in Ye, Will West, we live in Gogriel. Maybe, we don't get the illness, but they actually do have people who have got the illness and they're transmitting it. And those who become ill are the ones who may have certain features, which I'll discuss in a minute. Now, in the current issue of the British Medical Journal, there is a paper published from Zambia. I only saw it last night, which I think is very interesting. They carried out COVID-19 tests on people who have died in the community, not in the town, but just in the community. And they actually found that 20%, that is 1 in 5 people, actually had COVID. And so it might have contributed to their deaths. And I think that is the first published report I've actually seen of people dying in the community, but who actually had COVID. Now, most of the people who are susceptible to, everybody is susceptible to COVID, but those who succumb to COVID are those who may have diabetes, and we do have a lot of people with diabetes, those who are overweight, those who may have kidney problems, those who may have HIV, those who are malnourished, and those who are elderly. And all that is related to the fact that the older you are, of course, the less robust your immune system is. And if you've got diabetes, there are problems. And if you're overweight, you've got more receptors on which the viruses can latch onto. So it's very important that these are all taken into account. And the symptoms resemble the symptoms of a common cold. You may have a runny nose, a sore throat, you feel very tired, and the tiredness is far too excessive. And you may also have aches and pains in your muscles, and it can go on for a very long time, and you could sneeze. And the one thing that kills people is the fact that you develop a pneumonia, and that pneumonia tends to affect both lungs. people become breathless. So breathless that when they move a very short distance, even from one room to the other, they've got to sit down and they're panting for breath. That's number one. Number two, your kidneys may just pack up and fail. Or you may even have clots in the lungs, and you may have clots in your kidneys and resulting in kidney failure. And so it is a far more serious disease than we think. Before I come to the preventive measures, I will simply sort of stop there briefly, Marwan, unless there is something that you want me to elaborate on. We'll come to the prevention aspect of it, because if I talk too long, it's going to cloud people's minds, but I will just sort of round it off there for the time being, and then I'll come back.
Okay. If you're living in South Sudan or anywhere, a South Sudanese living anywhere, what is the best thing you can do to protect yourself and the people around you?
I think what is very important for us, the mask. The mask is very important. Women in Awil West were interviewed in the market, and they said that they've already heard about the mask and washing hands. And what they've done is to wear the mask when they're in the market, and they make sure that their market stalls are at least 2 meters away from each other. And the reason for this is because the respiratory system, nose, throat, and so on, is the commonest site, because those receptors, the so-called AC2 receptors, are very florid within the lung system. That's why we use the mask. And when you sneeze, you can generate a plume of droplets. And this has now been shown. You can generate a plume of droplets. And anybody standing within 2 meters of yourself will actually pick up these droplets. Second thing is, if you're going in and out of a room, and you're using the door handle, or you're using a communal toilet and you're flushing using the handle, the virus lingers on these surfaces, particularly metal and plastic, for at least 72 hours. So unless you're washing your hand, you can actually pick it up. And when you pick it up and you rub your eyes, because it can go through the eyes, or you pick your nose, or you eat when you haven't washed properly, it can also go through your stomach. In the South Sudan Medical Journal, there was a paper from Khartoum where a lot of people presented with symptoms other than breathlessness, abdominal pain and things like that, because these receptors are everywhere. And so it is very important that, one, use a mask. Number two, socially distance, a couple of meters away. Stay away from everybody. Yesterday, a physician who is equally retired, I used to work alongside him, came to my house to collect a paper for which he wanted a signature. When he rang the door, I immediately got a mask, went to open the door. He was standing about 2-3 meters away, and he said, "Could you put that letter on the door, move back, and I come and pick it up?" And this is now the behavior that we've adopted. Secondly, if possible, stay outside. Thirdly, if you are staying indoors, make sure that windows are open so that at least there is fresh air to flush out any air that is in there. And if you've got to sneeze or you're coughing, use a handkerchief so that you can at least cut out any droplets that get into the air. Some airline companies like Delta in the United States have now introduced systems where they can purify the air and ensure that people are not seated near to each other. All this is happening. New Zealand only had about 25 deaths. And most of them were in elderly people and in nursing homes. And that was because when the COVID epidemic broke out, they shut all their borders straight away. They reduced movements. The Prime Minister came on television, spoke to people, told them what they should do. Public health doctors came on television, spoke to people, and did all kinds of things to ensure that people understood, because it is human behavior in this condition that you need to do something about. In the UK, for example, they shut shops, they shut hairdressers, and all sorts of non-essential services, and only allowed people to go to the supermarket. And when you're in the supermarket, you also have to maintain the distance. And I think it is vitally important for South Sudanese to ensure that they actually obey these rules. And we're working now with the South Sudan Red Cross, the South Sudan CDC, the Rift Valley Institute, with a bit of funding from the Department for International Development to ensure that the message is sent out to the communities in South Sudan to ensure that people actually carry out all these social preventive measures.
Before moving on to other questions, you've just mentioned the lockdown in the UK, where businesses, small businesses, outlets, non-essential businesses are shut down. That was tried in South Sudan, and for obvious reasons, it didn't work. It doesn't work in third world countries, in poor countries where people, the government cannot give provisions to people while people are seated at home. So we've heard stories in South Sudan where people say, I might as well go and catch the disease and die, and feed my children, risk dying, but at least feed my children, than all of us dying of hunger. So we know that a lockdown of the form that has happened in the UK cannot be done in South Sudan. So if it is important that people must interact and people must go to shops and so on, what else can they do to protect themselves?
That's a very important question, I think. And for those who are listening, this is something that they need to talk to the government about. It's something they need to talk to leaders in the community. And when I say leaders, I mean the chiefs are very important leaders, church leaders, and anybody that works within the regions. Now, in South Sudan, we have no refrigerators in most of the community areas, so you cannot store food. People go to the market every day. And the economic life of the people is interlinked with what they can generate for their families on a daily basis. So lockdown is going to be practically difficult. And even the people who were interviewed by the Rift Valley Institute in those areas, Rubicona, Ye, and so on, what they're saying is that it is extremely difficult to apply a blanket lockdown in the communities. Therefore, what we need to do is to modify the markets. We modify the markets in such a way that people are socially distancing, and this should be inspected. They are socially distancing. They've got water using those tippy. If you look in our journal, May 2020, you will actually find some practical things where we have shown people using diagrams how they can have a system where you can have water dispensed for washing hands, socially distancing, modifying it, and ensuring that people are reasonable. And the people in South Sudan in the community, in those interviews that were carried out, made it absolutely clear that nobody seems to worry about them from Juba. They are just, it's a top-down system, and they're just told we are locking down. And what they're saying is that we are willing to obey the rules if you tell our chiefs, you tell our church leaders, you tell our community leaders what the right thing is to do, and we will carry it out. So it's very, very easy. We would have been speculating had this research not been carried out. But because the research has been carried out, we now know how we can actually help the people in the community. So that is the main thing. The fact that the economic life of the very poor people in the communities is so tied to the markets and going to sell goods on a daily basis that a lockdown is not going to be practical. A blanket lockdown. The lockdown should be within reason, and also to ensure that it is safe for the people in the community.
What symptoms should people be looking out for? How would you know that you are getting coronavirus, or you caught a coronavirus, and what do you advise people to do about it immediately?
Yeah, one of the, some of the common symptoms would be if you begin to feel excessively tired, when you're aching all over the body. You may have a sore throat, which is quite unusual. You normally don't have sore throat, and you get a sore throat. And for those who are quite seriously ill, you may be breathless. Slight movement makes you breathless. Or cough, which is persistent. I mean, all of us, most of us do get a bit of cough now and again, and then you'll cough and it just stops immediately. But if the cough is dry and persistent, it keeps going on and it's nagging you, and it's combined with feeling very tired, feeling very achy, and you may even have a fever. You feel a bit hot. I know the first thing people would do in our part of the world is, oh, it's malaria. And if the chloroquine is, or other things is not working, or maybe it is typhoid. You know, that sort of thing. But let's also concentrate on the fact that if you're iller for longer than you would normally be with a cold, then you need to seek help. Unfortunately, the facilities in the rural areas, health facilities, from what we found out, this is not me just saying it, but from what we found out on that report, are so sketchy that traditional healers are beginning to come in with their herbal medicines to try and treat people, which I think can be very dangerous. So if we need to come in, we need to make sure that people know these signs early enough, because majority of people have mild illness, so they would have these symptoms, and such people should really start to isolate in their own tukuls or in their own houses, so that people bring out actually.
Yes. Are you okay?
So
Unfortunately, we are struggling with your connection, Dr. Olizai. Could you try disconnecting and connecting again, please? Suddenly, your connection has gone very slow.
But did you hear what I was saying after the last few minutes?
No,
because I can hear you. Can you hear me?
No, we've been hearing you very well until a point. But let's try and continue from here.
Go out and then come in again.
Yes, you're okay now. Yeah. Let's proceed.
Yeah. So those are the signs. In summary, a sore throat, which is quite persistent, fever, body aches and pains, persistent dry cough. People must be very suspicious. And also coupled with the fact that 80% of the people will have very mild symptoms and they will still continue to function, but they can still transmit the illness. So these are important things that people must watch out for.
We know that in South Sudan, our hospitals, as you've mentioned, in the rural areas, but not only in the rural areas, even in Juba, to be honest, we don't have the best medical facilities to look after people who are acutely ill of coronavirus. In the absence of things like intensive care and ventilators and such, what can medicine provide to our people?
I think what is important now, the health measures are the most important, really. Because if you prevent the illness or limit it to what is mild, then you may not even need to have big intensive care units. The intensive care unit is going to be valuable for the 5 to 15%. 80% will not need it. It's very few people who get it, and it is those who may have diabetes and therefore get a serious illness, those who are older than 50 upwards, and those who may have other illnesses like chronic kidney disease, who may have HIV, or any disease that indeed will lower their resistance. These are the people who are going to need this sort of problem. And of course, in the long term, we have learned a lot of lessons. It means that we need to invest in our health services. We need to make sure that the primary healthcare services are very robust and the hospitals are smaller but very efficient, so that they can respond to needs within a short period of time. But for now, the public health measures are very crucial. Wash your hands, socially distance, at least 2 meters away. I know South Sudanese are very, very sociable people, and nobody wants to be defined as very selfish because they don't want to welcome people. No, this disease kills. We've got to change our attitude. It's a change in behavior which is going to give us an opportunity to prevent the disease. So by preventing it, you can have a small but efficient intensive care unit and treat those who are seriously ill. And the others can either be treated in a step-down ward or in a dedicated ward, probably just with oxygen only. But for people who will need intubation and who is going to need quite a lot of resource, a high resource service like intensive care unit requires, that we actually prevent the majority of the people from being admitted. That to me is crucial, the prevention. Hands, mask, and ensuring that you socially distance. These are the three key things. We are working through with the Rift Valley and the community engagement group, which I've been advising since the last time we had a discussion with you and Dr. Nikki Kindersley. We've been trying to get out information in different languages to different parts of the country so that people can read this information and start to prevent the COVID.
Yeah, we'll try to reissue this interview, at least in simple Arabic. That's my promise to you. We'll try to do that because it's meaningless if it cannot reach our people. We always say that just because we can speak English, a small minority in South Sudan, should not make us superior or entitled to any priority. And if we talk amongst each other, we are talking through an echo chamber. We are not serving our community. We must find ways in which our messages reach everyone.
Yeah.
Moving on, let's talk a bit about medication. We're going to talk about, I want to talk slightly about conspiracy theories because these are, in my view, they are very damaging. And I hope you'll be able to support my point that conspiracy theories around a pandemic of any kind, and in this case, COVID, this could be very damaging and could cause more unnecessary illness and death. In terms of conspiracies, I want to talk about two things. One is all the claims about available drugs. Are there any drugs available that people can purchase to treat coronavirus?
Unfortunately, most of the drugs that can be used and have had an effect have to be supervised in hospital. The cheapest and most effective of all this is a drug called Dexamethasone, which is a steroid. A study was carried out in the United Kingdom, which actually showed that anybody admitted in hospital who requires some oxygen, if given dexamethasone, a sizable proportion of the people will not require to proceed to intensive care unit. And a sizable proportion of these people, in fact, do recover, and it does prevent deaths. I think the figure is somewhere around 30 to 40%, which I think is very significant. But there are no over-the-counter drugs. I mean, chloroquine has been shown to be ineffective. It does not work. So nobody should delude themselves into thinking that chloroquine will work. And then the second one is just an intervention like inhaling steam or something like that. That does not work. And there are people in other parts of Africa who have used certain concoctions. None of those work. And now there are some newer drugs which are used for treating arthritis, diseases of the joints, which have been found to be very, very effective. But this can only be done within the context of a hospital. So those are some of the drugs which have come on stream. They are used for other things, but they've been repurposed to be used in COVID. So still, it takes us back preventive measures. Make sure you don't catch it. And the most effective, of course, the most effective thing now is the vaccine.
Yes, which we will come to.
Yeah.
But still staying on the question of medication, would you advise people to go to the market and buy any of these, and buy drugs at all that are claimed to be to cure coronavirus?
I think it is inadvisable. It is inadvisable because even as trained medical doctors, we are not recommended to treat ourselves.
So nobody should go in the market. Nobody should go in the market to buy a drug.
Absolutely, because you can either over-treat yourself, under-treat yourself, or even cause side effects. It is always better to get medical opinion so that a proper diagnosis is made and appropriate medication prescribed.
And in any case, as you know, there is no scientific evidence that any of these medicines available in the market actually can work. Yeah. Okay. No. Staying on the effective medicine like the Dexamethasone, 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 and also the rheumatoid arthritis drug that you mentioned earlier. Can this be available in South Sudan, or are they available in South Sudan, to your knowledge?
They could be, probably through units like the Juba Medical Complex. But if, for example, we find that they're included in the protocols, we can import them either from Nairobi or from Kampala, where they have a fairly robust pharmacy systems. These ones can actually be brought into Juba and kept within the where people are treated. But dexamethasone, it costs very, very little amount of money. I think it is probably less than £5 for a course. Yeah. I mean, £5 obviously. Yeah.
So would these be sort of the things that the World Health Organization would be talking to the government of South Sudan about and finding ways of providing this?
I am sure if the World Health Organization is requested, they would help. Because they have an office in Juba and they're on the spot. So the undersecretary in the ministry, the director for hospital services, the head of the Juba Teaching Hospital. I mean, all these people can identify their needs and maybe speak to the World Health Organization.
Thank you. One of the saddest statistics is, even in the West, in Britain in particular, as well as the United States, the rate of people of African descent, Black people, who are skeptical about the disease and also skeptical about vaccines, are disproportionately very high, despite the fact that we are also at the forefront of being one of the major victims of the disease because of the nature of the jobs that we do. The same ideas are also very rampant around in Africa and around our people, which then is another form of disadvantage, really. In this case, disinformation is putting us at a very greater risk when we are already a disadvantaged people. Well, what can you say in terms of these conspiracy theories? First, about it actually doesn't exist, the disease doesn't exist. Two, that the vaccines are there to destroy us, or they don't work, or they poison people. Can you say something about that?
Yeah, I think it is very unfortunate that there are many people, including certain leaders, who actually don't believe that the disease exists. Unfortunately, we have lost quite a few people. We lost the president of Zanzibar, or one of the vice presidents of Tanzania. We lost a president in Burundi, all to the same illness. And there are very many people who have actually been admitted to hospital. There were skeptics like the president of Brazil who did not believe in it, and he actually got the illness. And we've lost some very close friends and relatives all to the same disease. And some of them have been doctors themselves. And I do think that people must get away from this idea of reading fake news and saying that the disease does not exist. It does exist. That one, we should really put it to rest, that it does exist. Secondly, when it comes to the vaccine, we ought to show people that we're actually having the vaccine ourselves. I mean, on the 9th of January this year, I actually took the vaccine. And occasionally I do go and meet people in hospitals, and I have done some sort of jobs in hospital, like teaching, because I still examine. So I do go into hospitals and examine. And I've been in contact with people who have had COVID, but I've not had the COVID myself because of having the vaccine. So I think it is important that we have the vaccine. Many people fear the vaccine because of what has happened to Black people in the past, when experimentation have taken place on Black people. And in certain parts of Africa, some people have come up with the theory that the idea of a vaccine is to make Africans produce fewer children, to sterilize them.
Right.
That's not true. It is definitely not true, because we've seen people take the vaccine, and I've worked alongside Caucasians, and I've worked alongside Asians, and we've all stood in the same queue to have the vaccine. So these two different groups couldn't have conspired just to affect one or two Black people in the queue. So I think it is important that we have the vaccine, because we know that the first dose of the vaccine will prevent at least 80%. You have 80% protection against the COVID-19. And when you have the second one, it takes it to about 95%. And so it gives you another layer of protection. So I think it is very important. One, it exists. Number two, the vaccine actually works. And number three, it is not targeted against Black people. Now, the issue about Black people predominantly being affected is quite interesting, because when you look at areas where Black people come from, the West Indies, Africa, in particular, these two areas, the COVID deaths have not been as many as they've been in Black people who work in the West. Because Black people who work in the West work in industries and in particular economic situations where they are exposed. For example, bus drivers, they work as bus conductors, they work in meat packing factories, they are sweeping streets and things like that, or they are cleaning hospitals. Now, it is these situations that actually expose us. And those who work as doctors, many of them work in accident and emergency, very, very unpopular part of the hospital to work in, because there's so much work and so on. And so in the West, Blacks are exposed to areas where they are likely to come into contact with the illness. Whereas in Africa, West Indies, outdoor lifestyle, so the chances are reduced, but they are still there.
Okay. One more conspiracy theory, this idea that the virus was engineered purposely to destroy certain populations. This is also very common. Please, could you allay the fears of people on this one?
Well, I think recently WHO group went to Wuhan in China, where this virus first was identified in, and they've not been able to confirm that the virus either escaped from a laboratory or was engineered purposefully to destroy certain populations. But when you look at COVID-19, it is a pandemic. It affects the entire world. It affects Chinese, Russians, British, Americans, Australians. It affects everybody. So anybody who introduces a disease which is meant to selectively destroy certain people probably has failed, because you can't just selectively go and get Black people. No, it's not the case. If anything, the Black people have come out better, I think.
Thank you very much.
Yeah.
In terms of the vaccines, what vaccines do we have now? Could you name a few, and whether there are any differences between them?
Oh yeah, it's quite interesting, because I think there are possibly 6 in the market, but the fairly prominent ones are the AstraZeneca, which is a British-based one, and then they have one from Pfizer, the Pfizer vaccine that is made in Germany, that is a German one, and then in the United States they also have the Johnson & Johnson. I think the Johnson & Johnson one is just one shot, and apparently it has just come on stream. And there are about 2 or 3 others in the United States. So there are quite a lot around. Now, the AstraZeneca, or the British one, is the one that does not require storage in special circumstances. It's easier to transport and easier to sort of take to different parts, say, of South Sudan. In the last week, Ugandans have been vaccinating their own people using the AstraZeneca vaccine, beginning with the doctors. I've been following them on a WhatsApp group on which I am, and I've been seeing them actually having it. Probably close to 200 doctors have already had it. I think they are trying to vaccinate the doctors first for 2 reasons. One, to show other people that if the doctors can have it, we can also have it. And then number two, because they are at risk, being exposed to people who potentially may have the disease. So the AstraZeneca one, and at the moment, I think, appeals to many African countries because of storage and transportation.
But in terms of efficacy,
Yeah.
should anyone give any preference?
Well,
should people say, okay, I would like to have this vaccine instead of other? Is there any justification for that?
Personally, I would have had any. I could have just taken any because the initial studies that are coming through now, because this one is a new disease, we have no experience of it, and the whole world of medicine has come in quite heavy on it with different studies. And the good thing with medicine is that people share information. It's all in the journals, and we can read it, and we can apply what is recommended. And so the idea of preference really doesn't come in. What you want is anything that is going to prevent or reduce the seriousness of the illness. Our problem in Africa, obviously, is the vaccine chain. What you don't want is for it to be deactivated. I mean, the Pfizer one requires storage in special circumstances, like minus something. And so you require deep freezers of certain specifications and so on. But if it is transported to a place like Juba, it will be quite easy to use because you would have those facilities. Transporting it to Yei, Awil, Rubkona, and other places might pose other things which have nothing to do with the vaccine at all, just the logistics.
Okay, now coming to countries like South Sudan, is there a chance of South Sudan getting any vaccine? If it does, where would it come from and how much would we get? Obviously, you mentioned Uganda. So how is South Sudan going to have any access to vaccines? I think
it really would have been very useful if we had Mayen, Professor Mayen Achiek. If he was here, it would have really helped because this is now really down to the government of the day and the Minister of Health.
Have you heard anything? Have you heard anything at all? Because we heard rumors about 800,000 doses of the AstraZeneca vaccine being donated to South Sudan, but it was just an anecdote. We don't know anything about that. Have you heard anything about that?
Yeah, it looks, yeah, somebody called me from Nairobi once and said that they heard South Sudan was going to get some of these vaccines. What I think we in this forum should be interested in is how is it going to be rolled out?
That's right. That was going to be my second question, which is, Can we rely? Do we have the infrastructure to do it properly? Do we have the mentality and the institutional framework to say, okay, we're going to start this category of people first and actually do it honestly instead of people taking it to their villages or their cousins or things like that? So do you think in that respect that we have that capacity? And if we don't, do you think that we can employ someone, for example, like a subdivision of the UN or WHO to actually provide it?
I think the logistics are going to be so enormous that bringing external help is probably not going to be practical. So it has got to be in-house. And what I think is that, first of all, we need to define which groups we are going to vaccinate first. And the idea of vaccinating is obviously to stem the tide of the disease. And so the first group that we would want to vaccinate will be the healthcare professionals, those who work in the hospitals, places like the John Garang Uni, Juba Hospital, and any of the other hospitals. We need to vaccinate these people. Secondly, people who work in the transportation section, like those who are driving taxis and buses that are helping people. This is very crucial. Policemen, prison officers, prisoners, because these are reservoirs of infection and which can spread. So all these are important people. We shouldn't forget them at all. We actually need also to vaccinate them. And with the policemen, particularly the traffic policemen, they're in contact with people all the time and they're talking and generating aerosols and so on. All these people need to be vaccinated. Soldiers, because they're in a group and they're huddled together in large numbers, they also need to be vaccinated. Similarly, the cabinet often sits together, and sometimes they are shoulder to shoulder. These people also need to be vaccinated. And the idea of doing it is not preference for them because they are in a special position, but the idea is that we're removing a reservoir of infection.
Right. Because when they catch it, they will give it to others.
Absolutely.
Right. Thank you. Thank you. We've had a similar discussion before, Dr. Hakim, on a different panel that was a more global one. It was a regional one discussing Sudan and South Sudan. Now we're talking about our country specifically. And one thing that came up there was that the people were saying, you're locking us down because of the disease that I don't know anyone who's caught it. But I know that my cousins are attacked every day physically. I know that malaria kills so many people. I know that hunger is killing us. So in terms of priority, how high should we put coronavirus relative to our health conditions in South Sudan?
I think it should rate probably among the top 5, but maybe it is the top of the 5, in fact, for the simple reason that it kills very quickly. If you're very unlucky and you've got diabetes, you've got high blood pressure, and many of us Black people have high blood pressure without knowing we've got it until we've either suffered a stroke, a heart attack, or kidney failure. We never know. And a lot of the people who have had high blood pressure, diabetes, and kidney failure hardly ever survive it. When they get it, they're gone. A few people may survive. Therefore, it is vitally important that this disease is taken seriously, because there is no second chance. I mean, when people get it, they've had it. So we need to rate it very highly, and we need to let people take it seriously. The reason why people think they do not know anybody who might have died or whatever is because the majority of the people have the disease, but they have no symptoms until probably they die. As the Zambian study showed, the Zambian study actually showed that 1 in 5 people who have died in the community were COVID positive. So there are people in our communities who are COVID positive, but they do not know, and they are transmitting it. Secondly, we're not carrying out any testing. The testing would be very useful, except that it's going to be very expensive. In a place like South Sudan, it's going to be very expensive, and there's only one test center in Juba. And so it takes a very long time. Therefore, prevention is really the strategy.
Thank you very much. That really clarifies a lot, Dr. Olizai. I think we've covered a lot. It's unfortunate that the rest have not joined us for this discussion, but I'm sure we will organize another one, and we'll get yourself and Dr. Mayanachek to be with us next time to really specifically discuss how best we can use our cadres, how we can use our talents to help the health service in South Sudan. People like yourself, and I'm sure there are so many other South Sudanese top doctors around the world who are not in South Sudan, but who really, in terms of ideas, in terms of their contacts and so on, could coordinate with our people so that to strengthen our health provisions. Is there a final message that you want to pass on?
Yeah, the final message is the Rift Valley Institute report, the RVI report, which is in the South Sudan Medical Journal, www.southsudanmedicaljournal, all as one word, .com, and it is on the front page of the website. I think it is important that we read this report, because a lot of work has gone into it, and it covers all of South Sudan. We took representative areas, and it's good to read the attitude of the people, the feelings the people have expressed in that report. And once you know how the people feel, then it is very easy to help them.
Thank you very much, Dr. Olizai, being with us with RBC. And RBC apologizes for our failure to bring everybody on. People have had different problems connecting. We are going to look into this problem. Perhaps it will do more justice not to do things live, and take our time to record them so that they can reach more people. But thank you so much, Dr. Olizai, and we hope to have you again.
Okay, bye.